Yeah, one thing I must tell you, whatever data we have, the scientific data, which is conducted in a reasonable scientific manner, you get from either US or European countries. Unfortunately, in India, the data is sparse, though some teams are trying to build up registries and trying to have a study on the Indian patients, how these patients behave. But we know for sure that Asian genes, genetic susceptibility is different and almost 3 to 6 times more than either US, Chinese, or Japanese people, the incidence of the prevalence of coronary artery disease. Now, why this is happening? It occurs almost a decade or a decade and a half earlier than Caucasians or people in the whites. So if they have an average of 60, 65, our people get average heart attack, average age is around 50, unfortunately. That is number one. Number two, though there are several factors like genetic susceptibility, number one, hypertension, diabetes, bad cholesterol, smoking, metabolic syndrome, obesity, these are considered risk factors, and all of us cardiologists have been focusing on these risk factors to screen the asymptomatic population who have hidden heart disease. This is called risk factor stratification scoring system. All of us have been believing in that. Framingham score system, or European score system, or Q-risk system, or pooled cohort equation. But none of these risk factor stratifications have been found to be very precise. Most of the times they overestimate or underestimate depending on the age, gender, other factors. Unfortunately, if you see my ICU or anybody's intensive care cardiac unit, we see almost 60 to 70%, that means 7 out of 10 patients who come to our ICU, they are so-called low-risk category patients. That means, in other words, if the person comes to my OPD one day prior, when I ask or go through the scoring systems, I say that this is a low-risk category, I reassure, and within 24 hours, the patient presents to the ICU with a heart attack. Why is this happening? So the traditional risk factor scoring systems have been proven to be not effective in an individual, especially these are not applicable for Indian patients, number one. Number two, the hidden heart disease, we were giving a lot of importance to the symptoms. Only when the patient was presenting with chest pain or a palpitation or shortness of breath, we were investigating. What investigations? I will come later. There also we went wrong. The traditional risk factor or ischemia stress testing also misled most of us cardiologists. Now in the past 3-4 years, a lot of data is coming up, which I will share with you. So risk factor score systems have misled. So-called pre-test likelihood of a disease have misled, and the downstream testing also pattern also is fallacious. Lot of lapses, lot of misguidance has happened, spending billions of dollars, confusing the people, physicians, population, and there is no proper information. I must tell you, the misinformation in cardiology amongst the public, among the physicians, even amongst the cardiologists, the debates and all, so much that in no other department, so much of debates, wastage of time, adapting to newer things which are really effective, wasting decades. Sometimes it takes decades to adapt really scientific, facts. So that which are useful. I'll come to that later. Why the delay in adoption of the guidelines and also framing the guidelines is also delayed. So this is now why it is happening. The hidden heart disease, which we were thinking more than 50% of the stenosis of the coronary arteries is responsible for heart attacks majority. But now we know less than 50% stenotic lesions are the cause for more than 60-70% of the heart attacks. This is another thing. Once you know the angiographic picture, even when 30% lesion was there, I still remember about a few years ago, I was telling 30 years is normal, everybody will have. Now we know that 30% lesion is very, very dangerous if it is a lipid block. So this ruptures and suddenly it causes the heart attack. These 30% people can run marathon. So Jim Fixx was a marathon runner who was, running 20, 25 miles without any problem, and suddenly he died one day while running, and his autopsy showed all three vessels blockade, 80-90%. So the exercise capacity has nothing to do with the existence of the hidden coronary artery disease. And now we don't believe that symptoms should be there to screen the cardiac patients, especially in India. This is also now, it will be surprising for you to know that people who are more than 45 years, who are aged more than 45 years, if you have them here and then do the CT coronary angiogram, 40% of them will have hidden heart disease. They'll be absolutely normal, going to the gym, they'll be running. So screening the asymptomatic population is very, very important, irrespective of the risk factors in Indian patients. This is what we have realized after doing 25,000 CT coronary angiograms, picking up a lot of patients. The other way also is right. Many patients, thousands, lakhs of patients are treated unnecessarily with lots of medication just because they have high blood pressure, or they have diabetes, or they have some lipid cholesterol. No, there is another genetic susceptibility gene which is not identified, and many people are over-treated just because they have this thing, and then we have realized that appropriate precision medicine is very, very important. So this is one aspect. Now you're talking about Puneet Rajkumar, a wonderful actor, wonderful personality who has conducted seminars in Jayadeva Institute about how to control and how to prevent sudden cardiac death in young patients. He conducted a seminar. Unfortunately, he succumbed to it because he had discomfort in the morning. He went to his private doctor and he was not, sent in a EMS, so emergency medical services with a defibrillator, shock-giving medicine, and all these things, equipment and all. And on the way, he died, unfortunately, by the time he reached the cardiologist. That means there is something like a golden hour. Whenever chest pain is there, either in the periphery or in the city, or educated people or uneducated people, many people feel that it is gastric trouble because most of the times, 90% of the times, heart attack occurs with burning sensation in the pit of the stomach or epigastrium. Because heart is in the center, it rotates to the left, and the neuronal connection, unfortunately, when there is a heart attack here in the muscle, the brain perceives that some burning sensation is there. That is how it is mistaken. The word of gastric trouble kills many people. Many people give Pantocid or injection, then they say if it doesn't get relieved in the night, you go tomorrow to the cardiologist. By the time, many people are dead. Unfortunately, this is happening. This has happened with many people. And so the golden hour concept, the minute you diagnose or the minute the patient has got chest pain, unfortunately, chest pain again is misinterpreted. And 30% of the heart attacks are silent, or they are just very, very mild burning, and people just ignore. And misinterpretation of the ECG. ECG is normal. First ECG is normal in 45% of the people with heart attack in the first 1 hour. Unfortunately, misinterpretation of the ECG, misinterpretation of the chest pain, assuming that it is gastric trouble, then the denial of the patient, and lack of knowledge, lack of access, lack of transport, odd hours, a lot of things are resultant of this sudden cardiac death. Unfortunately, this actually, I get perturbed when, a savable life and a person on whom the family is dependent, he had pain in the night, and somebody said, okay, you take Pantocid, if it doesn't get relieved in the morning, you come. By the time he comes, he's in shock, he's in failure, whatever you do, he dies. So, lot of education has to go into the public, to the treating family physicians. Family physicians are responsible to save their patients, to identify the disease, hidden disease in their hearts, because they come to them with hypertension or fever or headache, and they miss the diagnosis for 10 years, 20 years. They have to find out a way, they have to identify the disease in its early stage, treat it, alert them so that they don't mistake it as a gastric trouble. So now the family physician's role, they are improving their knowledge, they are also trying to save the patients, they are trying to understand how to assess the hidden heart disease. And if you do this, we wouldn't have lost people like Puneet Rajkumar.